right, everybody. All right, we're back on the thing. It's nice to see almost half of us here. A nice, small but select group. But that's okay. Nevertheless, uh, so I thought I would add to so you can see that let me give you my logic because it was, I was unaware and I should have been more aware. So it's me, because I'm technologically old, meaning you grew up in that generation, we did not. And I was when students first started telling me we didn't have a textbook, I'm like, really? And maybe I heard about that within the last week, 10 days, and I started investigating it, and I got in contact with the gentleman who runs the full ed aspect of our bookstore. I don't know whether he's on site or not. And it's like, what's going on here? I've got students telling me they didn't get a textbook. Well, it is apparently if you had that book bundle, not that that's not my department, but the only way that you could access textbook or related textbook materials would have been for me to have done, because it was by definition had to be incorporated with Blackboard, which it was not. I thought that you could just log on to a site that I sent you at the start of the semester with my identification, whatever it was, and that was sufficient, but apparently not. So, and that's why I postponed everything, because and probably contributed to some of the problems we had with the first exam, was that students did not have, it's my way of thinking, adequate resources and or adequate time to utilize those resources. So to that end, if you didn't get a chance to look at all that email stuff, that was monumentally long. And I spent a variety of conversations with him, and which were email, and then on the phone for about an hour and a half with McGraw-Hill, who are the ones who run it, who run our. I don't have to sign it again, do I? Drive me nuts. How many times I have to sign in for that stupid thing? Just ignore it. And I'll show you. So what will happen, and wherever you find those things, and I said that it was, so we go to courses, and we get to your course, there's a couple of other, and I'm starting to put some modules. And I incorporated so I had to learn how to put it onto Blackboard and then do Blackboard from there. So, I mean, there's no other way. So, as I said, if you're at the Start Here tab, and some of the students have done it, maybe you have, and you work your way all the way down, now we're here. And we just use that as a dummy chapter. It's not something you have to read or anything like that. It was just to get it established. And I'll email everybody with this information. And I did before, for instance, earlier this afternoon, I did this, chemical and physical methods review, and there's an assignment. It's not for points. It's basically review of the chemical, physical, and methods of control. And I'll probably put a couple more modules in. So it'll give you something to start to review with over the course of the week, and depending on what your plans are during the break. And so I postponed it till after the break. That's my logic. I wanted to give everybody, it's good news and bad news. And I understand some people, there's a scheduling conflict, and we'll work on that, where it is. And so next week, I need you to, I always think it's a bad idea to put it the first day back from break, because a lot of people, they really haven't paid a lot of attention to school during break, number one, and maybe they're not ready to get into the swing of things. And so now, I mean, it would either have to be the Wednesday, and if there's a problem, we'll adjust individually, or the Friday after the break, whatever that turns out to be. So if that's today is the 4th, that'd be the 18th, 20th, or 22nd. The difficulty with that means that we're going to have 2 more exams squeezed in, and I'm going to have to figure out how to get that done. So it does open the possibility of having to do something on Blackboard and allowing a time type of thing. So all that's being developed. But I wanted to show you that in this initial few minutes before we get started. And so I'm hopeful that I'm hopeful it benefits more people than it does not. With the extra time to prepare, because there's a substantial amount of volume, and I certainly could not cover everything I need to cover in this chapter. And so without further ado, I'm going to start here and pick up where we left off, because I know we covered it. Yes, sir.
Since you're like full life, is the review video still relevant?
Absolutely. The review video has not changed. The material, the test will not change. It just is relevant. Some students have asked about what they benefited by doing these modules. I know maybe Dr. Robbins and Dr. Maurer, depending on who's teaching you, might utilize some of these things for homework or for assignments. They like that. I'm not a big fan of work product. I'm a big fan of tests. I mean, so again, I reiterate my point. Almost anybody in this class is eventually going to have to take a test to get a license to do something. And that test is not going to be, well, I'll do a couple of homework assignments to pass. They won't let you do that. You can't pass the test. You go, let me just talk to you and I'll tell you. No, you can't do that. That's what standardized testing is. You have a certain standard to get through. Nobody, that's the way it works. Unless the world undergoes a change in the next, year, which is not. That's always going to be the case.
Is there going to be a second part to your review video?
Oh, absolutely.
Okay.
I mean, I have to go. I'm going to go over it, and we'll actually have time to review here. That's what I'll probably do when we come back on Monday from break. I'll probably dedicate that to a
Okay,
review.
so there'll be like 2 videos then.
Oh, absolutely. I'll get busy with it.
Okay.
My wife's with her mom, although she's home tonight. Then where she's gone for 4 days, which means it's me, the cats, and the dog. Not necessarily in that order, because the cat will tell me what I have to do. He's a cat. So much for the animal population. First 8 minutes used up. Down we go. So, we kind of ended here. I have a tiny nugget on hantavirus and a bigger nugget on HIV. Hanta is an interesting virus that most of us would never see here. It's extraordinarily rare in Pennsylvania. Of all things, it comes from rodent droppings. And what happens when rodents droppings, when they get aerosolized, when they dry, sometimes it like kicks up and it stays suspended in the air and you inhale them. Very rare here. Very common in the southwestern United States. If you travel there, if you vacation there, or if you go to live there. And that could be anywhere between San Diego and Texas, all along that southwestern tier. There are a lot of respiratory illnesses that are there because, and you're going to see deep fungal infections are there, something called valley fever, because of the climate. In dry, dusty climates, if you have ever been there and vacationed there, dust storms swirl up all the time. You get these little like dust devils, these little it's very, very windy, and it's almost impossible to breathe. This stuff is in there. Okay, and this is potentially fatal. So you have to be very, very cautious about that. It's rare in our area. It would be extremely never ever happen in this climate, unless you were raising rodents for laboratory use, for instance. And that's when we see it here. That's there. It's interesting. Historically, it was the basis why it was in England. Medieval England is called the sweating sickness, because that was the characteristic of high fever, sweating, dead in 3 or 4 days. And that's why they discovered the link between things like plague and that with rodents. So, and they were remember the Pied Piper of Hamelin, that little allegory about how he chased all the rats into the sea. If you don't remember that, it was very interesting. And that was sort of the basis for that little tale, because they began to discover the association with rats and fleas and plague and things like that, historical. So we'll revisit that in respiratory diseases. So it's it's rare, but it's aerosolized. When you talk about something that's airborne, it stays in the air. COVID is when someone sneezes or coughs, it's airborne, then it forms droplets. It drops to the ground. These do not. bacterial disease, tuberculosis, stays in the air. That's why it's such a problem. So there's a distinction that we get to it, how diseases spread. Okay, Lassa we really don't see around here. Hepatitis B is now categorized as a DNA retrovirus. The mechanism is not clearly understood. And frankly, it's not a big trouble because most people have been immunized for it. It used to be what hepatitis C is today, the most common deadly form of hepatitis. Hepatitis B worldwide is significant. Which brings us to a major player and the reason why I have to cover it fairly fully a couple of times is because it's the kind of thing that those licensure exams look at. Because it's something that is very familiar. First of all, you have to know the difference between HIV positive and AIDS. They are not equivalent terms. HIV positive is someone who has been exposed to HIV, has developed antibodies, and positive means they have antibodies that are testable in their bloodstream. It has nothing to do with them having the virus in their bloodstream. They may have successfully gotten rid of the virus. They may have just had one exposure. And once you're HIV positive, if you are treated appropriately and take good care of your health, there is absolutely no reason why you're going to shorten your lifespan. Someone who does not do those things, or is particularly sick to start, conceivably could develop, and most likely will develop, AIDS over roughly 2 to 10 years. That's why it's characterized as a slow virus. AIDS means that the virus, which attaches to the single most important cell in your bloodstream, the helper T cell, that's the cell that makes your immune system works. Not only does it destroy those cells, it takes over them and they make more bad cells. So it becomes a little factor to make viruses, and in that 2 to 10 year span, in the absence of treatment, or the absence of good health, or absence of taking care of yourself, you will develop AIDS. That means your immune system will collapse, and by definition, it is fatal, which means it shortens your lifespan. Period. So you have to know about that. It's an odd virus. There's a whole thing about what they call transcription strategies. I don't do it. But the only one I do is this because it tells you how complex this virus is. Basically, it has to do with positive and negative sense strands, and I don't want to do that. The folks who do biomajor micro need to do that. And so that's the microbiology course that we do in the fall that Dr. Maurer happens to teach. He is more familiar. He does our immunology. So HIV is classified as a retrovirus. It means it reverses. It contains, among certain enzymes, one of which is called RNA reverse transcriptase. It has other enzymes, which is interesting. So basically, it reverses transcription. So transcription is DNA making RNA, and then RNA makes proteins. That's translation. The odd about this, we start with RNA. This enzyme reverses it and makes that RNA into DNA. That's a step where in our cells, there's almost no proofreading. That's number one why it mutates so aggressively. And that's the big problem with HIV. Remember, it's an RNA virus that acts like a DNA virus because it immediately goes from RNA to DNA. RNA viruses mutate, DNA viruses become latent. They stay in the cell forever. Many of them. That's what I call the worst of both worlds. That's why it's such a pain. It's useful because we're using that enzyme for gene therapy to resequence cells. The DNA then makes new RNA. That RNA makes proteins, and those proteins eventually make new virus. So it's a very complex process. And so there's a variety of these stages where we learn about that, how it works, and that's where we attack it with antivirals. And that's why modern therapy is a cocktail of 4 antivirals. It used to be called the triple cocktail. Now we've added another. It starts all the way with, as it starts to enter into the stomach. So there's a lot of, and we address that from a classroom perspective, at least to identify kind of how it works when we talk about antivirals, when we do antibiotics. So it's a very interesting virus. And the reason I make a big deal out of it, for any of you who are going to do patient care, there's a distinction on how, not how you treat somebody. You should treat everybody to the best of your ability. It's how your caution level is. An HIV positive patient versus an AIDS patient. If you get a random needle stick, blood splash from an HIV positive state, statistically, the odds, all it means they have antibodies. Antibodies can't hurt you. Probably 1 in 500 that you could develop, you could become HIV positive. An AIDS patient, by definition, those viruses are in all of their fluids all the time. The likelihood, I wouldn't say 100%, but probably more than 50%, if you get a blood splash, you're going to get the disease. I mean, when we looked at hepatitis C, I gave you that anecdote about my first wife. She was running the nursing home on evenings and weekends. She did all the sticks when they needed to have blood draws. She did it. The patient, elderly patient, they didn't know they had hepatitis C. They were combative. She got stuck or splattered, very often in your eyes, okay, which is an area where it can enter. You know, as blood splatters up, you don't even know where it all goes. You say, oh, I feel like that's in my eyes. Even if you rinse it out, membranes are easy to absorb. And it was all, and so she might have contracted it that way. Most likely, she had it from a transfusion back from 1981. We were trying to get pregnant as a couple, unsuccessfully. Her supervisor, her directress of nursing at the home, she knew very well. We said, listen, you need to get, I'm fine. No, you need to go to occupational health. And so the moral of the story is you write an incident report and you go to occupational health. All they do is they check you out. They do a series of blood tests for things you could have been exposed to, infectious diseases, hepatitis C, HIV, any of that stuff, syphilis, pick a nasty disease. Because anybody could have that in their secretions. She turned out, obviously I got that crying, oh my God, I'm positive for hepatitis C. Well, I think she probably got it from the transfusion, but that discovered it, and we were able to, she didn't require any treatment, but we were able to go to an infectious disease specialist that we knew, a doctor up in Butler, and he had a lot of experience with it, and thankfully they caught it before it was any problem. She did not have to have any treatment. So the moral of the story is you've got, and you're going to see that people with chronic, what we call chronic or persistent hepatitis C are in the same boat as AIDS patient. That virus is always there, and you are always potentially at risk. So wear 2 pairs of gloves, wear eye protection, wear a mask, wear whatever you got to wear. Give them the same good care you would give to anybody else. Gone are the days when somebody came in the emergency room and people cringe when they hear what we used to do. I'm working emergency room between 77 and 79. My ex was the head nurse at an inner city hospital emergency room, small hospital, a couple hundred beds in Philadelphia. And people would come with a gunshot wound, stab wound, and they'd be bleeding. And they'd come in and, we didn't wear gloves, masks, or gowns. It wasn't like TV shows, What's that show? It wasn't Grey's Anatomy 101. Everybody, she's a fan. I know. They come bleeding. We do this, bare hand. Yeah, no gloves, no nothing. I'm still here. It's the way we did it back then. You put pressure on a wound because they could die. So somebody could get there to get it stopped, at least. So, they come and bleeding up, whatever. So that's the moral of that story. So much for retroviruses. We did this stuff and we did that stuff earlier. I don't do a lot about bacteriophage viruses. What's interesting about them is what they can do. Basically, they either destroy, which is sometimes beneficial, they may be an alternative to antibiotics, or they modify and alter bacteria, which can be bad. Because a lot of the diseases that are nasty to us come from bacteria that have been altered. What bacteriophages can do is they can incorporate. It's kind of like a latent state, but latent not in the sense of chickenpox and shingles, latent in the sense that when that virus incorporates with the bacteria's DNA, it incorporates a new property. The fancy name for this, as you will see, I'm going through all these relatively because you don't really know about them right now, is a lysogenic infection. The one thing that you should note, going backwards just a little bit, is that the big difference between bacteriophage viruses and viruses that affect us, which are known as animal viruses, okay? That whole thing, that capsid and assembly, no matter what it is, doesn't enter the cell. I mean, it'd be too big for you. You have to figure that for the virus, for the bacteria. All it does, that's an assembly to inject the genetic material inside the cell. That's all it is. That's the big difference between animal viruses, the way we define viruses that affect us or other animals, and bacteriophage viruses. So when this process occurs, it's called, so it's infected, but it doesn't destroy the bacteria, it just alters it. So that lysogenic conversion alters the DNA due to the phage virus DNA. It's got a fancy name, it's called prophage. We have a name for that for HIV, it's called provirus. It's just, to people who are studying in the viral vernacular, that indicates a virus that has incorporated with the host cell's DNA. Indeed, that, as you'll find out when we start talking about antivirals, one of the antivirals is called an integrase inhibitor. It blocks HIV from doing that. It's one of the ways we treat it. Look at what those phages, they take regular botulism and make it toxic. Regular diphtheria, make it toxic. We're all immunized for diphtheria. The killer, most common of the killer strains of E. coli, the one you always read about, O157H7. That's where the toxin. Salmonella, food poisoning, causes a change in that LPS layer. Scarlet fever, one of the major diseases. Scarlet fever is very interesting. It's a very unusual response. It causes your immune system to go nuts. Those cells that we talked about in HIV, the helper T cells, that are the single most important cell in the immune system, it causes 20% of them in your body to go crazy, make a ton of chemicals. That's what they call one of these, and there's other things that do that. This is a streptococcal pyrogenic exotoxin, and it causes bizarre things that are frequently deadly. Before we had antibiotics, this was a fortunately common problem of strep pyogenes. Cholera, another deadly disease from contaminated water. So that's what I need to share with you about those aspects. So none of this, we did transduction, we're not going into it. This is stuff we do in the laboratory, since we're not doing that. These are viruses that infect us. We colloquially call them animal viruses. Because it would probably be better to say eukaryotic viruses, but for years it's been animal. And it's all about the receptor. A virus can't hurt you unless you have the receptor for it. on your. So if you hear about people who can't get a certain viral disease, probably genetically they don't have the receptor. And it's not, and that's why viruses take different paths. So some viruses can affect your skin, some viruses your gut, some viruses respiratory, because that's where the receptors are. So theoretically, a skin virus shouldn't be able to affect your respiratory passageway. A GI virus shouldn't be able to affect your skin. The problem is if you have an open cut or something that might create problems, and then that argues into hand care. So HIV is an oddball because it actually requires what's called a co-receptor. So it's pretty unusual. And I think we have an animation about it somewhere. So specific receptors, and because of that, okay, you don't see this overlap. We refer to that as the range of a virus. Normally when you talk about biology and you talk about range, we're thinking geography. Oh, it affects, it's like that one I told you about, Southwest, or it affects the Northeast, or it affects Central America. Range of a virus is very specific. It's how many different species it attaches. Rabies has an amazingly large range. If you're a mammal, you can get rabies. Okay. Measles are us. We're the host. Very limited range. So if I had a dog, which I didn't when I was a little kid and got the measles, my dog didn't have to worry. I didn't have to. I know, deprived. My dad worked 6.5 days a week. My mom worked. Hey, no dog. Okay. But say, and now rabies, multiple. The flu, COVID, those have a broad range, multiple species, and in there and some of the problems associated with it. So, and that's significant as well down the road. This is the big distinction in viruses that infect us compared to those bacteriophage. Yes, they have to attach, but effectively your cell engulfs those viruses, whether they're naked or enveloped. If it's an enveloped virus, it's got a fancy name. It's called membrane fusion. You don't have to know it. The bottom line is the whole virus, capsid and all, goes in. So your entire cell is exposed to what's called the nucleocapsid. If it's a naked virus, your cells phagocytose it. They gobble it up. And again, they'll gobble up the whole thing, and what's left when that phagosome opens up is the nucleocapsid. What we do that phage viruses don't do is we uncoat the virus. Fancy word for removing that protein capsid. Why is this relevant? Because the first line of antivirals were anti-uncoating agents. They prevented that. They were developed to combat, which was the most problematic of all viruses, the flu at the time. The good news was they worked if you used them early, and then eventually they didn't work at all because resistance developed. So they're historically significant, but they're not significant otherwise. You'll find when we get to antivirals, reason why viruses are such a problem, we really only have 3 major disease lines that we have useful antivirals for. Influenza, HIV, herpes. Are we developing more for things like RSV and hepatitis C? Yes, but not a lot. Okay, so the antivirals for a long time were very limited for whatever reason, and I'll go into the reasons when we start talking down the road, but that's not coming up. So what happens once they attach and they enter? They call it penetration, then uncoat. Once they uncoat, now they take over, just like any other virus, even in a bacteria. Just like that animation where we saw transduction, shoots into the bacteria, destroys the bacterial DNA, starts changing into a little factory to make viruses. Okay? So then it makes more viruses, then So it makes it makes capsid proteins, enzymes, more viruses, whether they're RNA or DNA, and puts them together. That's basically it. And you're going to see down the road that there's one of two ways they leave the cell. This is that portion that has to do with this 5-step infection cycle. I don't do this. So you can see it's positive and negative sense strands. It's annoying. So you can have single-stranded and double-stranded and positive and negative. Don't want to talk about it. Don't want to talk about it. The only one is the one that I have up there was the reverse transcription. And you can see, and again, even here they have the sense strands. Our bio majors go over this stuff in their courses because only certain sense strands make certain things in the grand scheme of what we call cell and molecular biology. Nothing that really is relevant to our course. So again, RNA made DNA, makes more RNA, and then basically makes either proteins or makes the genetic markers for more of the virus. It's just like I wrote up there, and I try to make it simplistic, less like this. And the same thing. So inside our cell, just like inside a bacterial cell, here we have the genetic material. We're going to assemble a capsid around it, insert protein spikes. Maybe there's certain enzymes that go into the genetic material. And at that point, we have a virus that's good to go. The big question is, how do we get rid of it? Well, how does it basically get exposed to the other side? Well, typically for a naked virus, like a cold, okay, it does this. It's inside our cell, and we make multiple copies. So remember, bacteria, you get a bacterial infection, you have 1, then you have 2, then you have 4, then 8, then 16, generation time, and double time. See, viruses, it's different. So arbitrarily, one virus enters, let's say it has we call it a burst size of 1,000. It'll make 1,000 little virus particles. The cell will burst, and that can then infect, theoretically, 1,000 other cells. And then the same thing happens over again. And the next time those 1,000 cells burst with 1,000 viruses, it can infect 1 million. So rather than 2 to the power, it's 1,000. That's why small. That's why. Trying to think of a good example of a really quick, that hantavirus, something that in 3 or 4 days, unchecked, and typically, remember when smallpox was abundant and back in medieval England, with no medical treatment, nobody knew what the hell was going on. They bled people, all that type of stuff. There was really no treatment. 3 to 4 days, they're dead. So they're rampant killers. And plague wasn't a whole lot different. It just took a bit longer. And that was a bacterial. So that's the idea of burst size. So most naked viruses reach a certain burst size. 500 to 1,000 is about right. And that's why in a matter of literally days, so think what happens when you get a cold. I mean, you feel cold. I've had one Friday night, overnight to Saturday. I'm like, ugh. And this was a week ago. And I'm still coughing a little bit. And the next thing I know is like, oh, I'm getting a cold. By Saturday, I'm not going anywhere. I feel miserable. By Sunday, I'm starting to feel better. I mean, if you only have a limited exposure or a cold strain that's not a problem, 2 to 3 days of being sick and you're better. You're still recovering. Maybe you have a residual cough, that type of thing. Stomach upset, same thing. Be a little careful what you eat. So there's a certain degree of limitation. Your immune system if it's competent and healthy, will help you get rid of that. Rather, how many times have you and I said to each other, oh, I had one of those 24-hour bugs? There is no such thing. It means you had a limited amount of infection. You began to notice what suggested to you that you were getting sick, and your immune system went, I got you. It's a good thing. Enveloped viruses, better issue for smallpox, bud or shed. What that means is they put little protein spikes in either the cell membrane or other membranes in one of our cells, and basically on their way out, it's almost like they're spit out. Like you had, it's a good analogy. You're making little icing dots on a cake. Something I'd like. No cake decorators here. No piping bag. Do you all know what I'm talking about? Thank goodness. I use that all the time. I mean, how else would you fill a cannoli? Right? Manicotti stuffed shells, ricotta, little lemon, little garlic. Pop that bad boy. Okay, so what happens in the naked virus is the cell basically bursts, undergoes apoptosis. Look at this. So here's the assembled virus. Here, just for instance, using the cell membrane, pops it in here. As the virus is getting ready to be extruded, popped out, so to speak, all of a sudden it picks up the membrane with the spikes, and voila, that's an artist rendition. This is the real thing. It's a cell spitting out viruses. I don't know what virus it is, but it's spitting out. Enveloped viruses because pick up membranes way out the door. The other thing I just touched on is duration. You have acute and what are called persistent or chronic infections. Either term is used. Acute, that cold. Comes quick, gets sick, goes away quick. Okay? Typically doesn't take long, depending on the severity. Maybe you had a bad case of the flu. Maybe it would take 5 days to get there, a week to 10 days to be there, 5 to 10 days to get rid of. It's still a relatively short development, lasts for a certain period of time and disappears. Persistent or chronic viral infections are what happens when somebody gets AIDS or when someone has chronic hepatitis C or persistent hepatitis C. Once it becomes persistent, they are always releasing the viral particles, whether saliva, semen, bloodstream, other tissue fluids. That's the high risk. When you encounter them in a patient to caregiver environment, that's the exercise. In the old days, we didn't do a whole lot other than maybe double glove and surgery. That way, if one of your gloves got nicked or caught, then you had another glove on underneath it. It was a little different. So you had, a gown, a mask, a cap, maybe some eye protection. But I mean, we didn't go as nuts as maybe they would do today. And so with chronic infections, your viral, and that's really how we classify patients who are making that transition to AIDS or hepatitis C in that chronic persistent. They examine what's called their viral load. You take a blood sample and you figure out how many viruses there are per unit of measure, per microliter or milliliter, whatever it is. And that's called the viral load. A lot of times in HIV, we look at that as a initial point. And that's kind of, and down the road, if you end up working with people who have this, it's an important number. It gives you an idea of just how likely they could contaminate something. So latent, that's the herpes, okay? You get it, it goes away, but it's there. It may come back, it may not come back. And there's any number of factors that can cause it to reactivate. Illness, immune system compromises, stress, emotional trauma, social trauma, divorce, a breakup, somebody dies, all terrible accidents. I have seen them all. So it gives you an idea of just some of the ones. Notice the herpes viruses. Epstein-Barr And you can see even in some cases it can lead to cancer. Cytomegalo, latent herpes, type 1 and type 2, oral and genital, chickenpox, shingles. HIV is classified as mixed because it can go either way. Okay, if it's untreated, then it can go from being latent to chronic when it comes to AIDS. B and C, if they're untreated, will always go to chronic. Much more common in C. And you see what happens once you have chronic hepatitis C. It means down the road, even though we now have antiviral treatment for C and hepatitis B, we have an immunization for, you are unfortunately going to likely have people who are going to have the potential for hepatitis, cirrhosis, liver cancer. This is sort of the chart. We see this a number of times. This is a typical acute, whether it's a cold or a flu. A certain amount of time to get sick, roughly the same amount of time to convalesce, and maybe even a similar amount of time to actually have the full-blown disease. If in the old days we used hepatitis B, if somebody got hepatitis C, never sought treatment, and who do we see this with? People who don't want to go to healthcare for a variety of reasons. IV needle, drug addicts, people who have been infected, from violent crime and things like that, or don't have a trust because they figure if they go to the hospital, then the police are going to be called in. That type. People who are reluctant to go to a hospital for any one of the sundry reasons. They don't get treated, and a lot of times they don't. It's like, I don't feel right, and by the time all of a sudden they say, I better start getting this treated, now you're 6 months, a year down the road, and you're starting to jaundice and weak, and next thing you know, full-blown hepatitis, and they're in trouble. The difference with AIDS, it's sort of like the hybrid of these. So herpes, cold sore, typical oral herpes, it's there, goes away, may or may not reactivate. AIDS, HIV positive, is here because you have a very minor, couple of 3 weeks after an encounter, you're like, you don't feel good. There's no magic sore. There's no giant rash. There's no giveaway that we'll see in other diseases. And what happens, that person, I'm better. And the reality is they're not better. And then if they haven't, and I said this the other class, and I say it to you without being judgmental, the people who really had problems with this back in the late 60s and early 70s into the 80s till we really knew more about it, were people who had multiple partners, and there was not a lot of protective measures taken. And a lot of time, and really the watchword in those days for maybe late 60s to late 70s, even to early 80s, was casual sex, casual encounters, one-night stands. Even though there's still a bunch of people are more inclined to use protective measures today. I told the class the same thing. Whatever your lifestyle is, your lifestyle. Choose whatever you want. If you're doing stuff like that, you owe it to yourself and anybody else you have contact with to get tested really regularly. You just should. I mean, that's just being responsible. It's your life. Lead it the way you want to. It's my view. So what happens is they didn't get themselves checked, and then all of a sudden, over a 2 to 10 year span, it went from this gradually up to that, and that's kind of what happens. And so this is just showing where they are, and I stopped it here, and I'll stop it here with the other group. This is an important aspect about how its involvement in tumors, and then lastly, the portion about prions, and that's what we'll be dealing with on Monday. Thank you. Have a wonderful weekend.